Good afternoon, and thanks so much for joining us today. I was just going to give a minute or two for participants to continue joining us or logging on. Thanks so much for taking the time to register. I'm Jeffrey Sims, one of the associate chairs for the department here in Health Policy and Management, also an assistant professor and an alum of the department from many, many years ago. And really appreciate you coming to join us for this conversation around rural health transformation. And on behalf of Dr. Kristen Ryder, who is the chair for our department, and Wenji Mao, who is the chair of our HPM Alumni Council, we welcome you and hope that we'll have a great dialogue today. We're really excited about our panel on today. Quickly, I want to introduce Dr. Mark Holmes, who is a professor in our department here at Gillings, but also the director of the Cecil Shep Center for Health Services Research, and also an associate dean here at the Gillings School of Global Public Health. We're going to turn it over briefly to Mark and let him begin our session. Dr. Holmes?
Thanks, Jeffrey, and appreciate you all attending on this afternoon. I'm going to introduce our two very delightful panelists who I want to get right to the main event as quickly as possible. First, I'll introduce Maggie Sauer. Maggie joined the North Carolina Office of Rural Health as director in June 2017. And one thing we're proud of here in North Carolina is that the state office is the first state office of rural health in the nation, celebrating its 50th anniversary in 2023. Maggie has a wide variety of job experiences with Foundation for Health Leadership and Innovation, with the North Carolina Medical Society Foundation. She was faculty in speech and hearing sciences at UNC School of Medicine. She also worked at the small school 12 miles up the road, but we're not going to focus on that. Maggie grew up in the eastern plains of Colorado, but's been living here in North Carolina for 30 years, and she received her Master of Health Administration from here at Gillings. She gets special points for the dazzling earrings today, which is on brand for the heels. So thank you for that. Carrie Cochran-McClain joined the National Rural Health Association as Chief Policy Officer in 2020, where she's the head lobbyist for the association is responsible for driving the rural health policy agenda. Carrie has more than 20 years of experience working in federal health policy development, including at Health Management Associates, the U.S. Department of Health and Human Services, and the Federal Office of Rural Health Policy. A native of Montana, Carrie got her doctorate of public health here at Gillings as well. So we have two alum here joining us today, and so I'm really excited to start us off with that. Okay, so we're going to spend about 52 minutes or so talking about the Rural Health Transformation Program from two experts. And we're not going to really drill into a lot of the basics of our HTP. We think that most of you probably know some of that. We will do a little catch up with that, but we really want to explore some of the less publicized pieces of that. And one of the advantages of moderating this panel today is that I actually know both of these panelists very well, and for both about 20 years have been, I call them my friend. So I know what you won't say, but we're going to push up to that border as much as possible just to try and make some entertaining. So before we kick off the RHTP, I think it's interesting to note that this is something that is both big and small at the same time. It's $50 billion over the next 5 years across the states. Most states get roughly about $1 billion over the next 5 years. That represents the $50 billion represents 150 times the annual budget of the Federal Office of Rural Health Policy. So in some ways, it's enormous and this tremendous opportunity to really change rural health, but it also pales with respect to the projected Medicaid cuts, as Kaiser Family Foundation projects $137 billion in the Medicaid cuts for rural health over the next 10 years. So let's start us off for the opening prompt for both of you. When people hear about the Rural Health Transformation Program, what do you think is the biggest misconception? What does it think people are getting wrong about it as they're talking about it? And let's start off with Maggie.
Yeah, so thanks for the question, Mark. I think the biggest issue is this is not about healthcare entities one at a time. I mean, being in different discussions with different states and things, I think it is about rural communities, about the collection of people who are in those rural communities, and what they can do to impact a number of the things that generally are barriers for them. So it's not about paying physicians and paying for healthcare. We've got to think about what not only we do at this moment, but what can be sustainable.
Carrie?
Mark, I have three. I know you said one, but I have three. So I'm blowing up your agenda just at the very beginning. I mean, building on what Maggie said, this is not your typical grant program. This is not a program that the federal government is putting out and saying, I'm going to give you this many dollars to do this many activities. It truly is intended to be a catalyst for innovation and redesign. And so there is I think, a different paradigm you have to have as you're approaching the work. Two other quick points. States really are the architects here. So it is a federal program. It was created and appropriated under HR1 by the Congress. CMS has, I would say, a scaffolding that they have created, but states have enormous discretion in what they're doing and how they're doing it, meaning that we are not going to have a unified picture across the country about what RHTP looks like at the end of 5 years. There is going to be a huge amount of variation depending on state implementation and priority. And I think the third area is that while this was talked about quite a bit in Congress as it was being developed as a way to save rural hospitals, I was on the Hill yesterday doing a staff briefing on RHTP, and I still heard people calling it the Rural Hospital Transformation Program. It is not intended. There is no guarantee this money is going to rural hospitals or rural hospitals alone, which I think, depending on where you sit in healthcare and where you sit in rural communities, is both a good thing and a bad thing, right? We know our rural hospitals are really struggling. I'm sure we're going to get into that. But a lot needs to be done to transform rural healthcare. And so I've really almost had to divide these two things in my mind. One is the Medicaid cuts and what's going to happen to our provider community as that comes into place. This is really an opportunity, again, a catalyst for change and innovation and level the playing field in our rural communities. They're not the same thing really at all. They get coupled that way, but in my mind, they are two different kind of parallel activities.
Thank you for that. So, Carrie, I'm going to build on your second point, I guess, which was that the states being the architect. What are some of the trends you're seeing as states are in the proposals and as they start to implement? What are some of the big bets that states are really looking at from a national perspective?
Yeah, I mean, I think we're putting a lot on states' shoulders, and Maggie is probably better to can speak to this with a more unique and on the ground viewpoint than I can. But states are really being asked to design, stand up, operationalize really complex models of transform in months, not years, right? Like if you were following this, the bill passed in July. I think some states and again, Maggie can speak to this. Some states really hit the ground running, figuring out like, what the heck are we going to do here? How are we going to get stakeholder input? And in some states that started right off, out of the gate. Others waited until September, late September, when CMS got the NOFO out, the Notice of Funding Opportunity, about what the program would look like. And then states had 6 weeks to design this program. And then, CMS, I will say everybody has moved very quickly, and I think to the best of their ability, given the statutory timeframes. But, we are putting a lot of bets on state agencies to coordinate across government, to move quickly to get funds out of the door, and that all the players like Medicaid, public health, regulators can all work together to move quickly and then partner with their state legislatures, which in many states are off doing their own thing, which they think should be done related to RHTP, not in alignment necessarily with what CMS has approved. So I think it's a big bet that there is some risk there in terms of putting so much states in a position to have to move to do so much so quickly, given just the infrastructure and bureaucracy we know exist. I don't know.
So with that context, Maggie, what is North Carolina doing, and why will it take more than 3 days to transform rural healthcare? I know we'll give you 5 days, but
Well, thanks. We appreciate the extra time, Mark. So just so everybody knows, I will tell you the department has been working nonstop on this and has really tried very hard to gather input from across the state. And building on what Carrie said, if people don't realize that really the governors are the ones who make the decision about who was going to write the application for the state. And so Governor Stein said, DHHS, you're responsible for doing that. So I think the thing that's important about North Carolina is, we have a lot of really important work that we have been doing over a lot of years. And, when you think about transforming things, it's, people may think that it's like, innovation, pull a rabbit out of the hat. This is about basically saying, what are the strengths that we as North Carolina have, and how can we build on those? So, we may have something that works in terms of sort of practice supports, practice engagement, hospital engagement, rural health engagement, those pieces. And how do you put those together in a network that functions in a way that truly serves rural communities? And so I think that's what you'll see. There's a webinar this afternoon, a town hall, and I think that Mark has sent that along. The RFA around what we're calling Roots Hubs will be announced and discussed at that time. But our hope truly is that all of you, even in your communities, if you're in these rural regions, do look at how your Medicaid region, et cetera, is engaging. Be part of the discussion, because that's truly the way that we're going to transform rural health and take the use of these funds to the next level. But without those community voices, it'll be the same old, same old. So thinking about workforce and so many of those things, along with behavioral health, along with chronic disease prevention, along with technology, along with value-based payment, what is it? What are the assets in North Carolina that we can bring to bear to bring it to the next level, to really make sure that works?
What I'm hearing, Maggie, and correct me if I'm wrong, is I'm hearing something that's going to be a little more regional in its approach rather than a statewide, not one size fits all, but much more tailored to the local circumstances. Is that fair and accurate?
That is absolutely accurate, because all of being in North Carolina, the western part of the state, the central part of the state, the eastern part of the state have very different needs and assets. And so what can those communities do through the Medicaid regions? And I should share at some point the Medicaid regions in case people don't know what they look like. But there are 6 across the state. Hopefully, I mean, there's still larger areas. I know North Carolina still functions a lot per county, and a regional approach sometimes is a little harder, but it is absolutely critical to have everybody in the boat going the same way, and not just have large institutions necessarily it's got to be the community who chooses who those administrators of those regional hubs will be.
Thank you for those who are putting the questions in the Q&A, and keep them coming there. I am watching them, and I'm thinking about where to inject them in the discussion. So I do think we'll get to all of them. And so with that, I'm gonna take one of these Q&As and toss it to Carrie a little bit. Can you talk a little bit about what the states are thinking? You mentioned that this is not really a hospital program at all, and there's talk a little bit about I'll call it the public health focus versus the healthcare delivery, and where you're sort of seeing the states kind of thinking about that, and what CMS was looking for in terms of the mix of that.
Yeah, definitely. So going back to just reminding people about the initial framing of the program. CMS laid out 5 strategic goals. The first of those being supporting the MAHA agenda, so making America healthy again, which really has that focus on chronic disease management, behavioral health, primary care, making sure we have access to those elements. And then there were elements around provider sustainability and thinking about how do we help ensure our rural hospitals stay viable, and not just hospitals, but our providers stay viable. We've got the workforce element that Maggie mentioned and thinking about how we're doing our training and placement. And then we've got elements around innovation of delivery design, and then how do we bring technology into that? So I think public health plays an important role in all of those. And especially as we think about, I would say, in my mind, that first one, I'm going to call it MAHA, but in my mind, it really is kind of a primary care element. I think there's a lot of opportunity for integration of public health and some of the foundation pieces there. And then also, as we think about care innovations and thinking about the role that public health plays in larger population health initiatives, and that important relationship between public health and health delivery. So that's kind of what immediately comes to mind. I don't know, Maggie, if you have thoughts on how that's playing out in North Carolina that are a little bit more on the ground, but those are the connections I would make.
Yep, I absolutely agree. And I think the difference is that with those elements, what North Carolina's done is gone through and selected very kind of specific ways to approach each of those elements, I guess I would say. And so that's the customization, I would say, of those larger elements is what you're going to hear from our group later this afternoon.
And Maggie's in a very awkward position, I think, because of the announcement of the RFA in 2 hours. So she's going to have to be somewhat cagey about that. But since I have no inside information, I can give a little bit on that. And Initiative 2 in the North Carolina RHTP plan is specifically focused on these elements: primary care, prevention, these upstream factors, and it's nutrition, it's access to care, it's a lot of the things that Carrie and Maggie were talking about. Okay, so Carrie, you mentioned, and I forget the phrase, there's incentive to get the funds out the door. And I think that's one of the things that I've been really, that's been very apparent in the approach of the federal initiative, and that is there is a clawback, reorganization. Milestones are very important for this program, more so than most others that I see. And states are going to be highly incentivized to meet those milestones, because if they don't, every September 30th, CMS is going to sit back and say, all right, you were short on this one. We're going to take some money back and reallocate it to other states. So there is this high incentive to really get the funds out the door. Of course, we also have this tension of being responsible fiduciary stewards of the funds, and how this is the first difficult question, I guess, is how are states thinking about this? And Maggie, to the extent you feel comfortable asking North Carolina, but this feels to me like one of the biggest challenges that the states are really going to grapple with.
Absolutely. I don't envy the position that states are in with that, with exactly how you laid it out. I mean, I think so I don't actually know this, but my interpretation, I've never heard anybody say this, but my interpretation of the timelines that were in the statute that CMS and the states must follow is that there is recognizing kind of some of the concerns, again, with the initial conversation of the state of rural hospitals and some of the vulnerabilities that rural hospitals will experience due to the changes in Medicaid. My thought is that there was interest in getting the money out the door, start to innovate. I say that because we know that there's not going to be innovation in place in time for some of the Medicaid provisions to come into place. But getting some of that money out the door now and quickly may help to offset some of those looming cuts. So That is my assumption. I've never heard anybody in Congress tell me that, but that's kind of my assumption to some of the speed of why this needed to move so quickly. But to your point, as you talk to states and as we talk to folks across the country that were writing the applications and will be implementing them, while Maggie and I talked about how the intent of the program is innovation, we all know, and you said this, innovation does not happen overnight. However, states really were focused, a lot of them were focused on shovel-ready projects, right? And low-hanging fruit doesn't necessarily equate to true innovation. So my sense of kind of what is happening now in a lot of states is, I mean, we're still so early on in that CMS, I don't think has even approved all of the final budget work plans after states got their final funding level. They had to go back and adjust to reflect their award amount in terms of what their activities would be. So I think that process is still going on. I know some states have been approved, and I think others might still be waiting. And then they're really trying to hit the ground running. And I think the North Carolina situation is case in point. And we're seeing a huge amount of variation in how states are looking to get the money out the door. So my sense in talking to a lot of states is this first year, they really are still a little bit more in that planning strategy, setting up the framework for what they want to do. As I talk to states, they'll be like, that's a potential year 3 project versus a year 1 project. So I think they're starting to get their mind around that. But to your point, I mean, in my mind, for some of the larger innovations that we want to see happen or transformations, whether that's a movement to global budgets or population health initiatives, my goal or my thought would be for this time period is that states are focusing on putting some of those foundational elements in place, and that getting enough of kind of some of that low-hanging widget kind of stuff in place will be assigned to CMS about their true intent in moving forward. What I would be concerned about is states saying, we got to get this money out the door. I want to make people happy. I'm going to check a lot of boxes and give a lot of money or a little bit of money to a lot of people without kind of that strategy, like Maggie started her remarks, without that kind of integrated strategic approach. And while we may move the needle a little bit in a whole bunch of areas, we're not going to have that true movement forward that we're looking for.
A couple questions, Maggie, about the hubs, and to the extent that you feel comfortable answering these.
Yeah.
I think I bundle these together as sort of like, what's the design of them? How much decision-making authority will they have? What are the accountability that they will have? How do we ensure that they are engaged with the community and accountable to the community that they're serving?
Yeah. And I feel a little bit like I can share a little bit more since Deborah was at our rural hospital meeting last week, and she talked about this a little bit as well. But going back just quickly to what Carrie said too, the design of the Rural Health Transformation Program in North Carolina was originally, they thought they would put it in our office, and primarily, for the reasons that Carrie said, to be able to track funds, account for those very specifically, we're setting up a new Office of Rural Health Transformation. And that's specifically to be very accountable to that. We believe there's going to be a lot of eyes on this in terms of audits and how the money was spent and why it was spent a certain way. So making sure that we can be as accountable as possible around that. And then when you start looking at the hubs, people say, well, what's a hub? A hub is really the organization. If you think about the way of creating this membership, this collection of people across the region, but it also has the administrative responsibility of getting the money out into the community for the community's use. So it can be anything around, some of those public health initiatives. It can be, certainly behavioral health. There's workforce initiatives in there, all the way from residency programs through high school and community colleges. And so the hub is really the opportunity to take a look at what does that need look like across the region. There are job opportunity locations across a region. How do you bring that focus in? And so to your point about how do we make sure it stays community focused, Mark, within the hub, they will be required to set up a governance committee. And that governance committee will need to demonstrate true community engagement in the decisions that are being made at the hub. So this can't be, you're raising your hand and you got 3 folks who are with you and you're going to go trotting down the road. It has to be like, are you talking to your community-based organizations? Are you talking to rural clinicians? Are you talking to the critical and rural hospitals in your region about all those things and how they come together? So that governance board is going to be extremely important. And I would say even at a state level, we're going to have a governance board or steering committee that set up from a variety of members who will help us think through and continue to monitor and give feedback about how this is happening. So, I think we're trying really, really hard, y'all, to keep this focused on rural. And I will also say, I have never gotten so many emails from people who are out of the state who know nothing. I mean, do they know anything about rural? I'm not sure they do, but boy, they're ready to sign up with the service, and say, we can be the best one to help you out, and I'm like, oh, you got to be kidding me. So you can tell how I feel about that. If you served rural, if you've got, rural, North Carolina rural, and you can truly attest that you've been in rural, doing that work in rural, you've got some street cred. But otherwise, it's kind of crud.
Maggie Sauer with the quote, street cred or street crud. I think you can write that down. That's a classic that I'll be using going forward. I love it. So let me pivot a little bit based on that last discussion. And that is, so Maggie, you've sort of mentioned about vendors. There's been a couple questions about opportunities for people in the community and whether that looks like a wide variety of potentials. And there's a couple Q&As here that I think relate to outside of North Carolina. So a little bit about, maybe I'll start with you, Carrie. What are you seeing about how states are approaching this challenge? And are you seeing are states generally taking a decentralized approach? What is procurement, for lack of a better term, looking like across the states? Is it organized? Is it 50 bazaars and alleys? How are states doing this? Is there any sort of central clearinghouse organization that you've seen, or is it really just 50 different approaches?
I mean, it's still early, but my sense is that it's 50 different approaches, but we'll see some themes kind of emerge about what that approach looks like. And just for it, kind of to show you the ends of the spectrum that I'm aware of now. And this is something, honestly, we're still trying to get our hands around in terms of what states are doing and how they're going to be getting the money out the door. One example is Iowa, I think, was the first out of the gate. And back in December, before they even had their funding levels, they were betting on getting some money and had RFPs out the door where they were trying to get ahead of state procurement processes and, kind of get those wheels moving. So they seem to be, as far as I can tell, really taking kind of that traditional procurement kind of approach to getting awards out. We have talked with folks in Alaska, and their approach is to partner with a community foundation that will be doing all of the grants management and oversight. So the money is going to that organization, and they're going to set up, the the notice of funding opportunities, the application reviews, the maintenance and reporting. So all of that the state has allocated to a foundation that has experience, and I would say probably can move a little bit more quickly um, in order to get that funding out. Another state, and I won't call them out on the call here, but I've talked to other leaders in this space who are doing everything they can to avoid their state procurement processes and are getting creative about how they might be able to get funds directly out to partners, still through state vehicles, but there may not be the same kind of public notice in the way that you would with an RFP, and really focusing on like who wrote in and who proposed projects and using that almost as their vehicle to get awards out. So it is, as far as I can tell now, and I think we are still early, and you can see like North Carolina is still doing some of their announcements. Like a lot of people are in that stage where they're making those announcements now. It has made it extremely challenging to figure out where to connect. And we are telling people to go to the state lead in each state, and talk with them. And to Maggie's point, like bring your portfolio of rural experience with you, because I have never met so many people who are interested in rural health, and it is amazing and we love it. But there is a definite concern because it is one of the few places right now where there is money in healthcare. I think everybody on this call hopefully knows rural is not just a smaller version of urban. It takes, when you're talking about vendors, when you're talking about services, you need to make sure that the tools and the services are right sized for rural, that they understand the constraints in rural areas, the opportunities, and like the workflows and how people actually provide care, and what the patient community and the individuals in the community, how they will react to things. So yeah, I think there's a lot of opportunity, but it is going to take a lot of a lot of oversight's not the right word, but a lot of transparency, I would say, hopefully, in how the processes are rolling out. And that's from the state, but all the way down to, I think, the people on the ground. How are you the right person to be given these funds that are really once in a lifetime, I will say, kind of funds to make change?
That's a great answer, Carrie. A couple of things I'll take moderator's prerogative and add on to that is I think it seems to me like a lot of people have a great idea and don't really understand how narrow a lot of these proposals are really going to be. So I'll plug the National Rural Health Association has put together a tremendous resource page that highlights what each state is doing. CMS has a state spotlight that's a little bit shorter. So do your due diligence. I have a LinkedIn post a couple weeks ago that summarizes some of the major themes that look like are showing up in each state. So if you have a whiz bang idea on something, I probably would start there and look for the states that might be a good fit. I think especially as Carrie and Maggie both alluded to, having some bona fides in the rural space, I think will be important. I'm going to use this opportunity to check off one of the questions, and that is making sure you're understanding how the state defines rural. North Carolina in particular defined rural a little bit differently than it normally does for this application. I think each state's doing it a little bit. So making sure that what you're doing is in scope. If a recipient has to be in a particular county, run that rabbit and see what that looks like. And then finally, the sustainability question. This really is a transformation. It's not intended to be 4.5 years and then stop. This is meant to be an investment of things that change, and including there's another reference here that, and I'll use this as the end of my prerogative, and that is what are the different strategies states are using to leverage these short-term dollars into long-term impact. And I'll give you both a chance to respond to that, Maggie, with your North Carolina.
Okay. Yeah. So the sustainability piece, I think, is going to be important. If this is something that is just beginning, I think it's going to be harder to sustain. And I'll give you a couple of examples. So one of the things that we have continued to talk about is how are we using like the North Carolina HIE in terms of sharing data? And that is something that's there, but it needs to be more fully developed. So that's one piece. Coming from an office that does a lot of placement around, providers of all kinds, or primarily primary care and oral care and behavioral health care. A lot of what has been discussed too is the use of AI to help write notes and help decrease the burden sometimes that providers feel in having to do annotate visits. And I would say, maybe that's certainly applicable to public health. And so is that a way to help retain our workforce? Because they're having an opportunity to be less burdened, I would say, by some of this. At the same time, North Carolina has received a lot of broadband dollars. And so, how do you build upon the technology infrastructure and enlarge that to make sure that what communities, community colleges, I mean, all these folks have to really address some of those concerns can build on the broadband infrastructure? And North Carolina actually got a lot of digital health literacy grants that have since been ceased. I guess I'll say that, but the infrastructure is still there. So that's the technology piece. I think is one element of that, and I believe public health is certainly in a position to help frame some of that work. And then I'll go to workforce. We've done a lot in North Carolina to, if you think about the number of workforce agencies right now in operation, we've got the North Carolina Center for Healthcare Workforce. We have two boards that are certainly interested from the governor and the secretary. And not to say that this supports boards, that's not what I'm saying. But there are initiatives that are already underway that will build on our ability to go further in making sure the workforce is available in rural communities and hopefully give people jobs in communities. In other words, you get your education, you do your residency or whatever that might be in a rural community. And also with our community college network, does that then make it available to people who maybe thought they had to go someplace else to get that training? But what are the variety of positions and things that the community colleges support? I was on a call yesterday and they were talking about dental hygienists and how important they are, and that the training for that exists in community colleges. So if you want to talk about workforce retention, is a dentist going to go to a particular region if they don't have a dental hygienist there to help support them? So, and I think public health can look at that too. Where are the workforce pipelines that we want to facilitate in these rural areas that, it may start in high school and move into community college, move into, other degree programs, but building on those assets. And I obviously I feel pretty passionately about some of that because I think North Carolina is really in a good place to build on some of that infrastructure.
So a couple questions that I would characterize as the RHTP limits the direct support. In some cases, is it a 15% cap direct for hospitals and other providers, 0% for things like food and other directly addressing social needs. So, maybe first to Maggie, even though there's not much support for providers, there are in the state plan two value-based payment designs. Can you talk a little about those and the design and the strategy for how that will improve the finances of rural providers?
Yeah, thanks, Mark, for the question. I think part of it is a primary care value-based payment model. And so the Division of Health Benefits is helping to design that. And part of it is trying to create ways in which providers can be incentivized to actually start thinking about value-based payment strategies. And we know that that has to happen, within their clinics. There's a marriage that has to happen with the PHPs, and to make sure that it's not only something that exists right now, but it's something that becomes of value to the rural health clinic or the primary care practice, as well as the PHP. Because if you're going to sustain it, those values have to exist in both places. So there will be more to come on that. I would say we're working hard to define that in greater detail. And that's probably something you're not going to hear as much about today in the webinar, because the value-based payment models will primarily be handled by DHB. And so look for more to come on that. I will say, particularly with the value-based payments for rural hospitals, the office with our HRSA dollars, our flex and ship dollars, have really tried to create opportunities for people to think about those things. And in North Carolina, the funds will be used, and we're trying to determine right now, it may be through the hub, it may be another way, because I think we're going to have some latitude with how this works. But it's really about creating feasibility studies about what would work within certain regions and certain hospitals, and then actually a design for how to make that happen. And so it's not something that we're forcing hospitals to do, but I think the incredible work that's been done with our friends, up north in Pennsylvania and other places, what may not work for North Carolina. I really want to give them a big salute. But, North Carolina's hospitals are primarily owned by systems who make decisions about what their rural hospitals are going to do. And so we're hoping that this will give voice to some of those rural hospitals, to allow them to think about the design and the feasibility of what would be needed for their communities. And so I think probably, honestly, what we'll get through with this RHTP program is those initial pieces of defining what is and is not possible, given, the environment in North Carolina.
And Mark, I want to jump just in on the sustainability question, because I think there are a couple other things to highlight more conceptually. Maggie gave some really great examples to how that would play out in North Carolina. I mean, one is, while the funds are really focused on, I think, innovation and transformation and catalyst building, in my mind, they also are playing an important role to gap fill. We've been under-resourced and have barriers preventing us from being able to move towards innovation. So I think workforce is a great example. I think there's some important capacity building that, if used right, these funds can help, for example, create preceptorships or support development of kind of that foundation that can help move innovation and then continue, because we've been able to fill kind of that gap, and really with filling it with sustainable infrastructure. I've talked to providers who have already said, I'm not coming in under any fancy new technology, because I'll have it. I'll figure out how to use it. I'll rework my workflows for it. It'll work for 3 years and the funding is going to run out, and then I'm going to be stuck with a technology that's no longer working. So we got to really think about that sustainable infrastructure and what we're putting in that can last the times. And then the other thing I would just flag that hasn't come up here yet is states have the opportunity to write into policy actions that they want to take to address a handful of priorities that were laid out by the administration. I think there is a lot of opportunity in especially the workforce area to think about development of compacts and licensure and scope of practice and moving the needle on some of the policy levers that could help with some of these, help sustain some of these investments. And then my hope is that someone like, oh, maybe the Shep Center will be helping to do evaluation as we see best practices models and learn from all of these investments, and then partner with someone like, oh, the National Rural Health Association to actually get Congress to move towards long-term reimbursement or policy or conditions or programmatic change that can sustain those innovations we found. So I don't feel like at the end of the day we're going to be able to check the box, but I'm hoping that we're a lot further down the road and have a lot more information that can help us figure out the direction we need to take long term.
What's exciting about the way you just described it, Carrie, is thinking of RHCP not as a grant program, but as a movement, a way to identify the barriers in individual states, find best practices, hopefully share best practices. It sounds like the CMS office is thinking about that and ways to spread that. Yeah. There's also a risk that um, even though this is sort of a golden age of rural health, not just RHTP, but CMS is rolling out a couple different innovative models that they've tried in the past and haven't had a lot of success with getting buy-in, but a couple of these recent ones might be more feasible in rural areas. That being said, it's not hard to imagine a gestalt in Washington of, well, we've been doing all these things in rural health for years. We just gave $50 billion. Do we still need these things over here anymore? And I think there is some concern at national and state level that RHTP will be the one size, done, we fixed that kind of thing at both the federal and state level. How can rural people interested in ensuring that rural communities remain healthy, how can they make sure that I'll say, capitalize on the opportunities of RHTP? And I don't mean that as a funding method, but as a stage where we can actually talk about these things, and also make sure that we're not losing resources, desperately needed resources on the back end. Do either of you have any thoughts on?
I mean, this is what keeps me up at night. I will say that now the timing obviously is all early in here, but if we look at the FY26 appropriations package of discretionary funding, rural programs got level and in most cases increases in funding. At the same time, just a couple months after, well, 6 months after the RHTP was included in HR1. So the initial evidence has not proven that to be the case, but we talk a lot about, $50 billion. We don't want at the end of the day for people to start checking the rural box, knowing that there's so much more that needs to be done. And so, the way we're framing a lot of this is just how we've talked about it, catalyst, innovation, but, making sure that we're always still talking about why we have some of the fundamental problems we have today, for example, with provider sustainability, having it go back to reimbursement models that work in rural, and making sure that we're telling kind of the full story of how we got there and have that be a continued part of the conversation. And I think this is really easy for me to say. Actually, I don't know if I'm going to say it or not. I'm going to pause there and see if Maggie has anything to add.
Yeah, so I think, we had this discussion a lot before all of us went to the NRHA policy meeting in DC a few weeks ago. Understanding what RHTP is and what it's not. So that when people went to go see their congressional delegation, making sure people understood those points about what it is and what it's not. And in North Carolina, y'all, I have to say we've been very lucky to get and have rural health support from the state for a number of years. So, for instance, we had a meeting with the Fiscal Research Division last week because they want to understand, how they're supposed to be looking at budgeting and monitoring and everything that RHCP funds. And by the way, we just got our money this week. And and so now we have another 30-day waiting period because the state government, the legislative oversight needs to take a look at it before we can spend any of it. So to your point, this is a reimbursement only program. This is not like, we're fronting you the money. This is like you're going to turn in invoices and we're going to pay you when those invoices are received. So that changes things a little bit. But I will also say that, for instance, the department or the office has had community health grants for safety net providers for a number of years. And that funding, which is about $15 million a year, is distributed, through an RFA to safety net providers across the state. Well, guess what, y'all? Some of those providers not only can pay for uninsured care, but we've had practices that now provide integrated behavioral health care, do telehealth, provide oral health, support and those kinds of things because they had that money to start what it is that that they would like to do. And so I'm going back to that because North Carolina, one thing I've said is we got to make sure that people understand what RHTP in North Carolina will fund so that it doesn't threaten some of those infrastructural things that we've been able to build some of these models on. So I always look at it as a bridge funding. So now, with the funding that they've been given, they're able to develop some of these models without fear of losing money or not being able to support certain things, right? They've been able to have some time to develop the model. And I hope that a lot of those will now be part of this larger RHTP regional initiative. So I think that's important. We have loan repayment dollars, rural health center dollars, and those kinds of things. We don't want to touch those, not just for not just because I'm looking out for ORH, but because they have been important in developing and continuing to support that infrastructure so that RHTP now can go further than what some of those catalysts were part of. And I think that's really important for people to continue to understand and advocate for.
Maggie, what I really like about what you said is I'm thinking of this as it is as permanent as any funding gets in this environment. But it's 4 years of certainty that this is there, and that's what you have to have in order to make the transformation that you need. I work with Carrie a lot on some of these Medicare extenders for the hospitals that have been given 18-month extensions for 2 decades now. And how do you plan your budget when you don't know what you're going to get paid a year from now? Can you afford to do the capital and make the investments that so many of these things take in years to turn around? So I think that's a great way to think about it. All right. So as we're coming up on the end here, last question to both of you, and that is, it's 4.5 years from now. RHTP is all over. We turn out the lights and sweep the floor as we're walking out. What do you hope we've achieved? What would success look like from this program? What are your goals and aspirations from this?
So I'll go first. Carrie's looking at me, so I'll go first. So first and foremost, that there are probably 3 or 4 things within each region that people from rural communities have really feel engaged and supported in the services that they're receiving from the network that's in their area. So if you're in the western part of the state, do I truly understand how to get the services that I need? That I have someone who can help provide those services to me. And the third piece of that is, I might like to really think about how I help the community and I have a job at the same time, because now are all these other resources that will help me develop that workforce and feel engaged. So, Northwest, Southwest, those things are not going to look the same. There'll probably be things that they can share, but they have unique ways of showing that they're addressing the specific needs of their communities, not just a hospital, not just a clinic, but how and public health. How are y'all working together to create networks of care and share data? And I hope that exists.
I know, right? Ditto. I mean, and I think that we see models of that, whatever that looks like in, throughout throughout the country. I'm going to say kind of regionalized models, but that also has, I think, a connotation for a lot of people. But that same kind of sense of how are we providing networks of care in our rural communities and starting to build that foundation, recognizing that more work will need to be done. I will say, a couple of other things. First, I want to recognize that in my mind, we've already had a win in that every state in the country now has a plan for rural health transformation, which I think is maybe other than when we first created the state offices of rural health 50 years ago, 30 years ago, 35. I forget how old that program is now, somewhere in there. I think that's the first time we've had that kind of like state momentum where we can really say we have this clear product. And that in itself is a win. I hope in 5 years they haven't just been put on the shelf with all the other strategic plans that we tend to do and walk away from, but that it really is something that states can show progress on and rural health is more integrated into how health is being provided in the state and in the county. Some states are already doing that. I think others could use some work on that. So that's one area. I would also say just kind of what we've talked about. I mean, I do worry a lot about provider stabilization and what that means for access to care in our rural communities. It's what I spend most of my day thinking about. And so while I am hopeful rural providers will be in the same place they are now, I am concerned that with some of the changes in coverage that are coming down the pike and changes to Medicaid, I'm hopeful that despite that, there will be clear bright spots across the country in how hospitals have come together, how communities and states have figured out to do whatever the next iteration is, whether that's value-based payment or global budgeting, or that we're a little bit further down the road of understanding what that looks like in rural, because rural has been so much left out of the population health model development in the history of kind of CMS. Although I agree with you, Mark, there are some really promising things out there now.
So just one thing I wanted to add, Mark, sorry, but the thing that I've really been surprised by is people think they know rural. Yeah. And the thing I always say to them is, have you been out there? Have you gone to these places? Have you been in Graham County? Have you been, in Pasquotank? Have you been in some of these places? And I'm sorry, you don't know rural unless you spent time there. Yeah. And I think, we all think that we're doing these things from 50,000-foot level. You have to be there. You have to be there in community with people to really understand their day-to-day things that they are challenged by. So I would just challenge everyone here to say, if you think you know rural and you haven't gotten in your car and driven out there, well, I'm just saying.
Well, with that, I think we'll wrap up. Thank you, Maggie and Carrie. You did an awesome job despite the complete ineptitude of the moderator. And so thank you for overcoming that deficiency. And Jeffrey, I'll kick it off to you to wrap it up.
Thanks so much. All I can say is, wow, Maggie, what a perfect way to close out the webinar today, having grown up in rural Eastern North Carolina. I say to folks all the time, you don't know rural unless you've lived there or at least spent some
Mhm.
time there. And I also had the privilege of working with the late Jim Bernstein with the establishing of the Office of Rural Health. And so I so appreciated that model that has continued here in North Carolina. And I'm glad to see nationally we've got great people like Carrie who are at the helm there making things happen. We have individuals like Mark Holmes who are evaluating and really doing the research related to the outcomes. And then we have Maggie leading our state office. And so, on behalf of the Health Policy and Management Alumni Council, we're appreciative of you. It makes us smile to see our alums doing such amazing work here in the country. And this webinar has been recorded, and so we'll make that available via our website. We will send an email once that is posted, and folks will be able to access it this way. But thanks again, Mark. You did a great job moderating. We appreciate you taking time doing that. Maggie and Carrie, thank you again for your time this afternoon, and we're going to now dismiss. Have a great afternoon, everyone.